everyone for being here.
Yeah, welcome everybody. My name is Cindy Brown. I'm the founder and co-administrator of the group. It's my honor to introduce Morgan Hart, who is the other administrator of our group, and Lahoma Naktrab, who is our wonderful technical person that knows Zoom and gets all these PowerPoints put together and loaded for us. So I'd like to thank you for that. I'm going to talk about the disclaimer next, and then we'll get going. There we go. All right. By participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a physician-patient relationship. The content here is for informational and educational purposes only, and because each person is so unique, please consult your healthcare professionals for any medical questions or treatment options. Dr. Trevino, welcome. So happy to have you again.
Oh, nice to be here. Thank you so much.
Thank you for taking the time on a Saturday afternoon for your patients and other ill people. So Dr. Trevino, he is a licensed and board certified doctor in internal medicine. He received his medical degree in 1982. Dr. Trevino completed his residency at the Albert Einstein College of Medicine in the Bronx with an associate fellowship in integrative medicine. Dr. Trevino, how long have you been practicing medicine?
About 35 years.
And in those times, how many patients have you treated with autonomic dysfunction?
So I think we're up to about 1,500 now.
Wow, that's amazing. When you, what got you interested in treating us? Because we're all so complicated and different.
I think I just started treating people, and then people just started to come. So the more they came, the more people came, the more I had to learn about it. So and just been a learning experience from then on, just continuous learning basically. So I like that.
Yeah, and Dr. Trevino not only diagnoses, but he also treats autonomic dysfunction, which is, as we all know, very hard to find somebody that diagnoses and treats. So at this time, I'm going to hand it over to Morgan.
Okay, hi everybody. So I am going to go ahead and introduce a case study for Dr. Trevino, and then we are going to go ahead and get some of his thoughts on it. So let's see here. Okay, so here is the comprehensive history and physical examination for a patient. The patient's name is Jessica Jones. Her date of birth is July 24th, 1995. So she is a 27-year-old female. She comes to the clinic with a chief complaint of repeated episodes of getting flushed and itchiness over the last few years, and she has not been able to identify a cause. So Ms. Jones is a 27-year-old Caucasian female presenting to established care as a new patient. She reports repeated episodes of flushing and itching over the last few years without an identifiable cause. Ms. Jones stated these episodes started approximately 5 years ago. She initially thought they were seasonal allergies, but they have progressively gotten worse in severity. She reports flushing and itchiness as intermittent, and the location frequently changes on her body. The locations include her throat, mouth, and arms, and she rates her symptoms as a 7 out of 10 severity. Since onset, the symptoms have progressed from random episodes of itching and erythema to anaphylaxis. She reports never having issues with allergies before until this started. She underwent allergy testing with no significant abnormalities found. And Ms. Jones reports keeping a diary to track her episodes, with the most consistent pattern being exposure to scents like perfumes, trying new foods, changing soaps like laundry detergent, and sudden changes in temperature. She reports that taking Benadryl 25 milligrams as needed does help a little bit. And she also reports episodes of fatigue, insomnia, tachycardia, nausea, abdominal pain, and hives. Her adult illnesses for her past medical history include the diagnosis of dysautonomia in the form of postural orthostatic tachycardia, She has Ehlers-Danlos syndrome and Hashimoto's thyroiditis. All of that was diagnosed at age 25. Let's see here. Her medication allergies include penicillin, Cipro, morphine, erythromycin, and baclofen. And then for food, she is alcohol intolerant. She's allergic to red dyes, and both of those cause gastrointestinal distress. Her current prescription medications include metoprolol, fludrocortisone, midodrine, and Benadryl as needed. And then for her review of systems, she reports having fatigue, lightheadedness, skin rashes, itching, flushing. Her head, headaches, her eyes itch, and she has secretions. For her throat, she reports itching and swelling of her tongue. For respiratory, shortness of breath, wheezing, and for cardiovascular, palpitations, tachycardia, chest pain. For GI, she reports cramping, abdominal pain, nausea, diarrhea, and musculoskeletal, she reports joint pain. For neurological, she's positive for headaches, confusion, and weakness. For endocrine, she reports heat and cold intolerance, diaphoresis, and for hematologic, easy bruising. So, Dr. Trevino, what sticks out about this patient, and where do you even start a workup for someone like this?
So yeah, thanks so much, Morgan, for doing this and reading that. The first thing that kind of sticks out is that you have somebody who has already been diagnosed with autonomic dysfunction and who's probably has hypermobile Ehlers-Danlos, although we don't know that from the history. And then also has an autoimmune disorder. But what sticks out is a few things that are interesting when it comes to mast cell disorders. So when it comes to mast cell disorders, they're not typical like allergies. So allergies usually are IgE mediated. And what that means is that you have an antibody that forms against a particular allergen. So if you're allergic, for example, to peanuts, then every time you eat peanuts, you're going to have an allergic reaction because you have an antibody, an IgE, that is already developed towards that. With mast cells, you could eat peanuts one day, have a reaction, and then a week later eat peanuts and nothing happens. So when somebody comes in who already has been diagnosed with autonomic dysfunction and autoimmune disorders and hypermobility, who's having a lot of allergic issues, and they've been to the doctor, to the allergist, they've been tested, nobody can really figure out what they're allergic to, or there's no consistency to their allergic reactions, then that is like a sign that tells you, oh, maybe there is a mast cell disorder happening in this person. So if it's so what we're looking for is something to be consistently inconsistent, which sounds a little weird, but that's what we're looking for. So if it's consistently inconsistent, it seems to be getting worse. The other thing is, when we went through the review of systems, it seems like her other disorders are really not under good control. And when we deal with people who have all 3 or 4 disorders, autonomic dysfunction, hypermobility, autoimmune disorders, and some sort of allergic, and inflammatory responses to things, you have to really try to control all of them in order for people to feel better. So that's going to be, that sends a signal to me that not only are we going to have to deal with the mast cell disorders, but we're also going to have to probably make some changes in the medications. The third thing that sort of sticks out for this patient is that she's on metoprolol, and metoprolol is a beta blocker. This patient has had anaphylaxis. So beta blockers, not that you can't use them, and people do just got to be very careful with them, maybe not use them as first line, especially in people who have anaphylaxis, because they can interfere with the treatment of anaphylaxis. They can blunt the response. And so beta blockers, you got to be very careful with. The other thing that kind of sticks out a little bit is that she has some environmental allergies and some food issues, and I can't remember, and some she sense and so this person also has some chemical issues. So for so many years, people have chemical sensitivities, and they go to the doctor, and doctor doesn't know what to do, and they get worked up, but and now finally we have a disorder, mast cell activation disorder, or the mast cell disorders that could explain why there's multiple chemical sensitivities, and if we treat those, then that could be of some great help as well. So those are the few things that stick out of her history and physical. We can so basically, what are mast cells? What people haven't heard of mast cells. So mast cells are white blood cells that are pretty much all over the body from head to toe, and they have these little granules inside of them, and you can see a picture. And those granules, when they release, they produce a lot of substances that then create an allergic inflammatory response. But that's not all they create. There are some people that think that mast cells have hundreds and up to thousands of functions in regulating the immune and allergic response. And they're the first cells that are supposed to decide, when you're exposed to something, is this a foe or an enemy, or is this my friend? And if the mast cell decides that whatever it is that you've been exposed to, whether it's on the skin, something you ate, something that went inside your nose, is this substance something that I need to create an inflammatory response or get rid of it? Is it a bacteria, a virus, a parasite? So the mast cells are the first responders that are in charge of deciding what is going to be the appropriate reaction to whatever it is that you've been exposed to. And of course, we are exposed to hundreds of things on a day-to-day basis, maybe thousands of things: bacteria, viruses, parasites, fungus, all kinds of things. And so they're very important in keeping us healthy. But with mast cell activation disorders, what happens is that for some reason they're just not functioning well. So when we suspect that there's mast cell disorders, we have to try to differentiate between, is this a disorder of the bone marrow? Is this an inherited disorder? Or is this a mast cell activation disorder, which we really don't know what causes it, but the mast cells are just not working properly. So is it a disorder where the mast cells are being overproduced, or is this a genetic disorder like alpha tryptophanemia? Or is this a disorder where the mast cells look pretty normal, but they're just not acting properly? So, so I don't want to really get into the, talking too much about mastocytosis, because it's a pretty rare disease. You do have to keep it in the back of your mind. You do want to make sure that you don't have that. But most people that we see that have all these disorders usually will end up with mast cell activation disorder. So what are we going to do with this patient who now has autoimmune disorder, hypermobility or Ehlers-Danlos, some sort of autoimmune disorder, and now we're suspecting that she has mast cell activation disorder. So the first thing is can we make a diagnosis with lab tests and other things to come up with a diagnosis? And of course, the first test that we always want to do is a tryptase level. Now, the problem with tryptase level is that you can get a tryptase level, but if it's normal, it doesn't rule out mast cell activation disorder. There are also 24-hour urine tests that we can test for histamine, leukotrienes, prostaglandins, and the metabolites of these we can test them in the urine as well, and those can also help us diagnose mast cell activation disorder. So we always want to get a tryptase level. Now, the tryptase level is a little bit tricky, and the reason why it's a little bit tricky is because, well, number one, if in disorders, in genetic disorders like alpha tryptosemia, if it's over 7 or 8, that's considered abnormal. Now, on the lab testing, a tryptase level of 11 or higher, at least the lab that I use, is considered abnormal. And with mast cell activation and with mastocytosis, usually we consider that mast cells should be over 20 to consider mastocytosis, although it doesn't have to be that high, and it's not always elevated. So it's a test that we always get. Most of the time we do it several times. So if you have a normal tryptase level and you have a reaction and you can go get another tryptase level, that'll help with the diagnosis. Tryptase stays in your system for about 3 hours, 3 to 4 hours. So you're supposed to, if you have some sort of an allergic anaphylactic reaction, you're supposed to get your tryptase level between 30 minutes and 3 or 4 hours afterwards. And if it doubles or if it's high, and then you get another tryptase level when you're not having any reactions and it's normal, then you can pretty much say that the mast cells are involved in this disorder. So tryptase is an important test. Unfortunately, if it's normal, it really doesn't help you too much. Same as the urine testing. Urine testing is difficult as well because it has to be kept at a certain temperature. It's difficult to collect because it's a 24-hour urine testing. It may also be normal if you haven't had mast cell reaction, an allergic anaphylactic reaction. It may also be normal. So all of these tests, even though they help us in making the diagnosis, they're not pathognomonic, or even if they're negative, it doesn't rule that you don't have it. So you really have to go with the clinical presentation as well. Now, as far as alpha tryptosemia is concerned, you want to also make sure that this doesn't run in the families, because if it runs in families, usually this alpha tryptosemia is an autosomal dominant disorder as well. And so if it runs in your family, if people have these same kind of things, then you can think, oh, maybe I need to get genetic testing for alpha tryptosemia. In alpha tryptosemia, if your tryptase level is above 8, then we consider that a positive test. So so your tryptase level can be normal, can be above 7 or 8, and that would suggest alpha tryptosemia, or if it's even higher than that, then we have to worry about mastocytosis, as well as the urine testing as well. So, so the next thing is, what are we going to do about it? So, the first thing that we have to do is identify triggers, right? So we want to identify triggers of any kind that we can. And also we want to identify if you take any medications, are you allergic or are you having a reaction to what the pill is made with or the excipients that the pills are made with. And if you can start to accumulate a list of things that trigger, then you can start avoiding those things in the medications that you use. And it also, you can start accumulating a list of things that can cause problems. And in this slide, you can see things that commonly cause problems: opioids, alcohol, non-steroidal antibiotics, and then all these environmental: heat, cold, exercise, vibration, stress. I want to just say a little something about venoms. So people are allergic to bees and wasps, and if people get a bee sting and they just develop a red old whelp there that comes and goes in a few days and is pretty painful, that's a good thing. But it's not a good thing, but it's not as bad as what could happen if you have mastocytosis or mast cell activation disorder. So if you get bitten if you get a bee sting, and you go into a hypotensive anaphylactic shock, that also gives us a clue that this is a disorder of the mast cells and not an allergic disorder. Because when the mast cells are activated, for some reason, which I don't think we understand, the mediators that trigger hypotension are more frequent. So if you have somebody who has a bee sting or wasp sting and they go into shock and they are hypotensive, then you got to worry about this. Is this a mast cell disorder? So then the next thing is, what are we going to do? So let's say we order the tryptase levels, they come back normal, and now what are we going to do about it, right? So the second part of the criteria for diagnosis of mast cell activation disorder is if you respond to the treatment. So if we give pretty benign medications, antihistaminics, leukotriene inhibitors, mast cell stabilizers like cromolyn and ketotifen. So we give these pretty benign medications, and if you can tolerate them and you respond to them, that is the second part of trying to make the diagnosis of mast cell activation disorder. Now, if your tryptase levels are very high, of course, I would at that point recommend that you're going to need further evaluation with both genetic testing for the KIT mutation. If you're suspecting alpha tryptosemia, you're going to need genetic testing with the TPS-AB1 for hereditary alpha tryptosemia. Although that test is not readily available everywhere, and insurance companies don't like to pay for it yet, but it's certainly, you can get that test as well to make sure you don't have hereditary alpha tryptocythemia. But once that is but if you don't think there's anything going on like that, then the next step is to start the treatment. And the treatment can be very tricky. The treatment can be very tricky because you can react to the excipients in the medication, and that can create problems in trying the medications. The medications that we use are histamine 1 blockers, histamine 2 blockers, leukotriene inhibitors, and mast cell stabilizers, as well as we can use Xolair, which is an IgE antagonist, a monoclonal antibody that's an IgE antagonist. So how do we go about that? How do we do that? So the first thing is we start off with histamine 1 blockers, and I think we have a list of all the histamine 1 blockers there. And you can really try anyone you like. Sometimes it takes trying several of them before you find the one that you like the most, that doesn't cause a lot of drowsiness and that you tolerate the best. You always want to start with the lowest dose possible, and then you want to increase it to the therapeutic dose, whatever that may be, or even go over the therapeutic dose if you're having a good response to it, or maybe an incomplete response, you may need a little bit more. So we want to start with H1 blockers. And the H1 blockers are listed there. And then we want to go to the H2 blockers. And the H2 blockers are usually, nowadays, all there is as H2 blockers is the famotidine and the cimetidine, because I think they removed ranitidine because of they were having some toxicology problems with it. Axid, I don't see much. I guess you could use that one as well, the nizatidine. So usually Pepcid or Tagamet or famotidine and cimetidine are pretty readily available. Then you would add that. Then the third thing you would add would be a leukotriene inhibitor. So what we're trying to do is we're trying to stabilize the mast cells as much as possible and see if you respond to them. The same thing with the H2 blockers. You want to start with the lowest dose possible, then increase it to the therapeutic dose. Once you're stable on the therapeutic dose for a few days, then you can add the next medication. The leukotriene inhibitors are singular and acrylate. You got to be a little bit careful with those because those can have a tendency to cause depression. So if you have tendencies towards depression, you may want to hold those off a little bit or use them last. And then the mast cell stabilizers are usually chromalin and ketotifen. And the ketotifen, unfortunately, you have to buy from a compounding pharmacy. They have it in Canada and Europe as pills, but here in the United States, we don't have it as a prescription. So we have to get it from a compounding pharmacy. So you want to add the leukotriene inhibitors, and then you want to add the mast cell stabilizers. And then once you're on all these medications, be on them for hopefully at least a month and see if a lot of your symptoms get better. And that can include all types of symptoms. It can include your GI symptoms. Now, one thing that happens with mast cell activation disorder is that people have too much acid secretion that is being produced by the mast cells. And because of that over acid secretions, a lot of times on top of the H2 blockers, which are sold as antacids, we have to use PPIs, proton pump inhibitors, like the ones that are on the screen right now. And those we use in conjunction. So the proton pump inhibitors, they don't actually do anything on the mast cell, but they actually help with the gastric part of it. And then the other medications that we use are there just to kind of give you an idea of all the medications that we use to treat mast cell mastocytosis. I'm sorry, but we do use a monoclonal antibody, which that you can use as well if you're not getting complete response with other medications. That's called Xolair, which is an injection that usually you have to have some sort of urticaria to get it approved by the insurance. But if you can get it approved by the insurance, it's a shot, sub-Q injection every 2 weeks. And in some people, that works very well as well. So it sounds like we're already treating the disorder, but we're really, all we're doing is trying to make a diagnosis, because in order to make a diagnosis, you have to have some sort of response to these medications. But the problem is that you can have problems with the excipients from that these pills are made with. And then if that's the case, then you have to go to a compounding pharmacy and compound every single one of these medications. And you can use various things to compound. A lot of times the compounding pharmacies have different types of dairy-based or wheat-based or soy-based excipients. But they have others that they can use, like rice-based. And in some cases, we use distilled water, although distilled water doesn't keep very well. The half-life of something that's in distilled water may not last as long. And the same thing would go. We'd have to do one at a time with the medications and see if you would respond to that. So it may take a month or 2 months of just trying these medications before we can even say if you have a diagnosis of mast cell activation. And so that's why it's a little bit cumbersome. But if you're patient and persistent and you try each medicine one at a time, a lot of times you can make some progress. So I think that is what I pretty much have to say about the patient and about what the next steps would be. There is a couple of slides that are on the PowerPoint to talk about cutaneous mast cell disease, which occurs in children, usually around the age of 2. They have a very characteristic rash that occurs with them. They need a biopsy of the skin to make the diagnosis. Usually it's very treatable. It's more of a benign condition, the pediatric mast cell, cutaneous mastocytosis. And I don't really see that many kids, although we do see plenty of kids with mast cell issues. You're going to need some help with your pediatrician and probably a dermatologist to make that diagnosis, and then to start the treatment as well. One thing that we really didn't touch upon is steroids. Steroids, sometimes we have to use them as well, especially for people who are having severe reactions and very frequent reactions. But when we do use steroids, we want to use them for the least amount of time possible at the least dosage possible, because we want to try to avoid the long-term complications of steroid use. So pretty much that is all I have for trying to figure out what is wrong with this patient that we presented earlier. Now, the thing that we also that is very important is that you have to take all the other disorders into consideration, because if you're having if your autoimmune disorder is out of control, then your mast cells are going to be out of control as well. If your autonomic dysfunction is out of control, then that's going to make your the other disorders as well be out of control. And so you have to figure out a way to treat all the disorders as best you can, so that you can get the best response, and so you can feel better. So you have to make sure that you treat the autonomic dysfunction, that your POTS is under good control. You have to make sure that your autoimmune disorders are not out of control. And so a lot of times you're going to need a lot of help from other doctors, including dermatologists, rheumatologists, to try to, and as well immunologists, to try to get things under better control. I guess the next step is where do you go for help? We have a ton of links that you can log on to. And I think the next step is going to be to try to answer any questions that you guys may have.
Lahoma is going through some of these slides, and I'll also post this as a Word doc. There's a lot of really good information in the slides, so we really encourage you to, read the Word doc too. There's just so much information on mast cell that there's no way Dr. Trevino could get to all of it in a short session.
I think we got the basics, and
Yeah.
I think sometimes it's confusing to read all of that for most people. So trying to keep it simple, trying to make it understandable, that's the main thing. So anybody have any questions?
So we did have some people submit questions.
Okay.
And I think the first type of question we received is, what type of doctor normally treats mast cell?
So the problem that we have is that mast cell mastocytosis is maybe taught in medical school for about a minute, so it doesn't get a lot of attention. Mastocytosis is a very rare disorder. So you can go your whole life and never see a patient with mastocytosis. So it's not in medical school, it's not something that we see on a day-to-day basis, like diabetes or hypertension. I mean, anybody who goes to medical school comes out with a lot of knowledge about diabetes and hypertension and heart disease. But unfortunately, mast cell activation, we just don't have a lot of education. Now, of course, there's a lot of people that are trying to change that. Kelly Freeman with a Dysautonomia project and Dysautonomia International, and there's other Mastocytosis Society and Ehlers-Danlos. All of them are really trying to get the word out, and it's getting a lot better. Anybody can really treat this. I think any family practitioner, but unfortunately, any internist, an immunologist is going to know more about mast cell activation disorder than probably anybody else. But you're going to have to look for people who who are used to treating this disorder and that have some experience with it. It's not an easy disorder to treat. You have to have a lot of patience. The other thing that happens in our current medical system is that everything has to be done in 5 to 7 minutes. So you see a patient in 5 to 7 minutes. I mean, as you could see from our history of Mrs. Jones, she has 30 different complaints. And how do you get to 30 different complaints in 5 to 7 minutes? It's very difficult. So, but having said that, I think things are changing. I think if you can find somebody that will sit down with you, who's willing to learn, that's the person that you want to get. So if your primary care doctor is the kind of doctor that doesn't think he knows everything, then he's open to learning, and that's a wonderful thing. If you're a doctor, if you're open to learning, then you can research and then start treating. So any doctor, any family practitioner, any internist, any immunologist should be able to help you with the diagnosis and treatment. Unfortunately, there are very few specialists in mast cell disorders. Now, when it comes to mastocytosis, that's a disorder that is a type of bone marrow cancer. It's where your bone marrow is producing abnormal mast cells, and that diagnosis really needs to be worked up and treated in a place where they are used to that diagnosis, and because that's going to require genetic testing, bone marrow biopsies. So it's gonna. So if you think there is mastocytosis, that's a whole different ball game, and the treatment is different. We use chemotherapeutic agents for that. Also use all the other antihistaminic type drugs and mast cell stabilizers, but that's a whole different ball game. And for that, you definitely need to go see a mast cell specialist.
One of the brochures that I posted, and it will be sent out to all of you guys, is a brochure to take to your doctor that explains what mast cell diseases are, in hopes that if you have a PCP, like Dr. T was saying, that's open and interested in learning, you can take that. There's also an ER protocol and a mast cell card that you can cut out and keep in your wallet. So if you're ever out and you have an attack or something, then you'll have that card to show the ER or EDS or whoever comes, EMS comes and gets you. Dr. Trevino, when is Xolair appropriate?
So Xolair is a drug that we've been using for many years. It's a wonderful drug for asthma. People who have severe asthma who are not responding to the normal inhalers that we give, and they're having recurrent attacks, usually will go on Xolair, and it's a game changer for people with asthma. And then it's also used in patients with urticaria. So if you have what's called dermatographism, which is where you scratch yourself and you develop a little red welt after you scratch yourself, that's a form of urticaria. So if you have that, it's indicated for the use. The insurance companies will pay for it. It's 150 milligrams every 2 weeks injection. And so I would consider it in anybody who we think has mast cell activation disorder, who has the urticaria, the dermatographism, which is very common in mast cell activation.
Okay. How do you feel about using IgG for MCAS?
So good luck trying to get IgG for MCAS. I don't think you're going to get the insurance companies to cover it. If you have another diagnosis where you have an autoimmune disorder, maybe you can get it.
Unknown caller.
I don't know that it actually works. It does, IgG does function as an anti-inflammatory. So it may work to some extent, but I don't think it's the primary treatment. IgG is $100,000 a year. Insurance companies don't like to pay for it. So if you have another disorder and you use it, it may help a little bit.
Okay. Do allergy shots help MCAS symptoms?
So traditional allergies are IgE mediated. So if you have allergies that are IgE mediated and mast cell activation disorder, so non-IgE mediated allergies, then the part of the allergy part may help you. So if you treat the IgE part of your allergic inflammatory reactions, you got to be very careful. But yes, I think they could help.
Okay. And one of the questions I can answer, where do I find a specialist in Boston? I have a very, very, very extensive list of physicians that came from the TMS for Cure website, which is the Mast Cell Society. So we'll be posting that. Then Dr. Trevino, if patients are having a routine colonoscopy, do you recommend requesting a biopsy be taken and stained for mast cell?
So part of the way that you make the diagnosis of mast cell causing a lot of the GI issues is that you may have a lot more mast cells. And I don't remember exactly, but I think if you have more than 25 mast cells per power field, then that is suggestive of mast cell activation disorder. I don't routinely recommend it. If your GI doctor is going to go in there anyways, then yes, get a biopsy, stain it for tryptase, and see if you can figure out if you have abnormal amounts. If you have a lot of mast cells in different organs, that could also point to a sign of mastocytosis as well.
Okay. If a patient has MCAS symptoms and also they're a POTS patient, what inhaler is best for that person to use?
So of course we have cromolyn in the nebulized solution. So if you have mast cell activation disorder, and let's say you're not responding to the traditional long-acting, short-acting, and steroids inhalers, so the LABA/LAMAs, the short-acting bronchodilators, long-acting bronchodilators, and inhaled steroids, then you can also add inhaled cromolyn, and that seems to work in a lot of people.
Okay. Does anyone else have any questions? No? If you do, after reading through, yes.
Oh, I'm sorry that what you did answer it. I'm sorry. Never mind.
Okay. If I'll go ahead tomorrow or later today and post the Word doc so you can be reading it, and the other documentation that I found that I think is important for you. But if you do have questions, don't hesitate to reach out to me. I could always send Dr. T a list of questions, and then, you know, I could get his answers and post them So we're here to help. I think we've decided to not do a session in December due to the holidays, but we will be doing one in January. And I'd love to hear from you on what topics you would like to hear. We're very open and flexible, and we just want to be able to present to you information that will help you to feel better and or take to your doctor to get, hopefully start treatment. Dr. Trevino is taking new patients, and he does do telemed. So we provided his information in the resource documents. If you're interested in potentially becoming a patient, give his office a call. The number's on there, and we thank you so much. Dr. Trevino takes his time to do this, and he provides such great information. I just feel honored that he does this for us. So thank you, Dr. Trevino.
No, thank you all for everything. Thanks for preparing this. Lahoma, Morgan, Cindy, thank you so much for helping me out with this. I could never do all this on my own, for sure. So thanks a lot. I appreciate it.
You're very welcome.
Everybody have a great Saturday afternoon and weekend, and we'll get this edited and up about 2 weeks, and I'll start posting different documents today and tomorrow for your review. So thank you so much. Have a great day, everybody.
All right, bye.
One thing I did forget to mention at the beginning, when you sign up, there will be a survey. So if you want to answer that, it's pretty much just what topics are you interested in and was this helpful? That'll just help us with future offerings. So thank you again.
Great. Thanks, Lahoma.
You're welcome.
Bye, everybody.
Bye.
Bye, thank
Bye.
you.